Jill Mansbrook from King's College London, and I'm delighted to be able to chair this afternoon's event. Welcome to this first event. Before I start, we've got a few housekeeping instructions. There's no fire test planned for this afternoon, so if the alarms sound, follow LSE staff who will gesticulate where they are quickly, or we'll start them running. We'd also be very grateful if you could turn your mobile phone to silent or whatever, but please do tweet if you're so inclined, because that's really important at these kind of events. So the reason why you're here today, hopefully, is to hear about a new collaborative study called Comprehensive Approach to Modelling Outcome and Cost Impacts for Dementia. But as nobody can really say that, they've shortened it to what you can see here, which is the title MODEM, which is really a great truncation of all those terms. This study is funded by taxpayers, so that's by all of us, under a joint initiative to fund dementia research from the Economic and Social Research Council and the National Institute for Health Service for Health Research. And as you can see, you've probably gathered, it's a project involving loads of institutions throughout England: London School of Economics and Political Science, Universities of Southampton, of Sussex, of Newcastle, and the think tank International Longevity Centre, UK. And so from the first part of this session this afternoon, we're going to be hearing from some members of the research team about what this project is doing. After the break, we're going to be hearing various responses to it, so hopefully you'll be able to have tea and mingle, and then come back for the second part of this afternoon, and there'll be a panel discussion at the end. First, we're going to hear from Professor Sube Banerjee, lurking at the back somewhere. Going to run down as if it's the Eurovision Song Contest to take the stage. So, beaucoup de points for you, Sube. And we're going to start here, and we look forward to hearing first from this terrific event.
Thank you very much. It's a great place to be here. And here are the results from the prize. So, dementia. I've been asked to start off today by just setting the scene and saying a few things about dementia itself. And so we start with a projective test for you here. We have some clouds there, and we have some sun, we have some sky. So is it a good time to have dementia, or is it a bad time to have dementia? Clearly, dementia is a devastating illness that causes immense problems for those that are affected, and immense problems for the families that care for them, and immense problems for society as a whole in trying to deal with it. There's nothing funny about having dementia, there's nothing good about having dementia. However, are things changing? Is it possible that the times that we have now are times where there is the possibility of positive change for people with dementia? So is this a sky that is getting clearer and better, or is this a stormy sky looking at the future? Well, taking as my theme for the day the late and great Ian Dury's song "Reasons to be Cheerful," I believe that there are reasons to be cheerful about dementia. I believe that the services that we will be able to provide in the next 20 years will be substantially better than the ones that are now, but that evidence is needed, information is needed of the sort that we will generate through MODEM, and that will make the difference. But I think there are already reasons why we need to be cheerful. If we look back just 5 or 10 years, things were very different in terms of what people understood about dementia and the priority in particular that dementia was accorded. So one of the reasons is that we know much more about dementia. This is the growth in publications on Alzheimer's disease by decade. In the 1960s, there were less than 100 publications on Alzheimer's disease. In the 1970s, as a whole, there were 290. And things have grown. And now, in the 2000s, it was more like 40,000, and will be more like at the 120,000 level in terms of publication. We know much more is going on, much more is being spent on research, and clearly there's a lot more that needs to be done. There's a lot more that needs to be understood. There's a lot more that we can understand out there. But things are moving, things are changing, and that's positive. One of the things that we know about is the numbers of people with dementia. We know that there are 34 million people with dementia worldwide, and that, in technical terms, is a lot. Yeah? There are a lot of people with dementia worldwide, and it's not just a problem for the developed world, it's a problem for the developing world also. Low and middle income countries are just as affected at the moment with people with dementia, and the growth that will happen in the next 30 years the doubling and tripling of numbers of people with dementia that we'll see, which is a function of the success, the tremendous success that we have had in terms of being able to deal with health problems, both in the developed world in terms of heart disease and cancers and strokes, and in the developing world in terms of increasing longevity, is driving the numbers of people with dementia. So we know that by 2050 there will be over 100 million people with dementia worldwide. So we have a predictable challenge here, a challenge that is a function of our success, but we also have the knowledge now that this will happen. And we know about the costs of dementia. We know that dementia is a remarkable illness in many ways. Dementia costs the world $600 billion per year. And that's a lot of money. If dementia were a company, that would make dementia the largest company by turnover in the world, bigger than Walmart, bigger than ExxonMobil. And half of that money is real money spent by developed economies on long-term care for people with dementia. And it's good news that there's loads of money being spent on dementia. Because if there were nothing being spent on dementia, it would be very difficult to think of re-engineering our systems to be able to meet that challenge. But because we spend and potentially waste money on how we care for people with dementia at the moment, there's the opportunity there to re-engineer this, to change things so that we do things better. But again, if we're to do that, we need good quality information, and that's the sort of information on the results of what we do, what we'll do if we change this one thing, what will happen to the costs overall. And again, that's part of what MODEM will be there to help. If dementia were a country, it would be the 18th largest economy in the world. This is a different size of problem compared to other things. So dementia costs more to our health systems than heart disease and cancer and stroke together, put together. And we have to ask ourselves whether the same priority is accorded to dementia as heart disease and stroke and cancer put together. And the answer is no, just to let you know. But it's changing. The priority of dementia is so much higher than it was in terms of the national dementia strategies that we have, in terms of the G8 or G7 or G6 or whatever it is now. Dementia challenge, the World Dementia Councils that have been created. Things are changing and changing for the better. There are reasons to be cheerful. And the second reason to be cheerful is that we have got an idea about what some of the keys are to making this work. So in terms of better diagnosis of dementia, we are already doing it better. We know what the problem is. In the UK, only 44% of people with dementia ever get a diagnosis, and when they do, it's late in their illness, a time of crisis, when it's too late for them to prevent the harms that happen in dementia. There's a gigantic amount that we can already do in dementia, which is about giving good quality information and care to individuals, which is about supporting carers in their own homes, enabling people with dementia to stay in their own homes for as long as they can, and making the care homes that they may need to go places where it is fit and good for people to be cared. And we already know loads of stuff about how we do that. And the fundamental problem is that most people with dementia don't know that they've got dementia, so that accidents happen in terms of care. And we can change that. We know that we want 70 or 80% of people diagnosed, and that's not everybody, because not everybody will want to know, but most people do want to know, because knowledge is power. Knowledge enables you to make choices. Knowledge enables you to decide what you wish to do later on. People suggest that ignorance is bliss, but ignorance causes confusion in dementia. People have a real problem that's going on. The earlier they know, the better. And that's what policy suggests. And we have emerging evidence from things like the evaluations of models like the Croydon Memory Service here that show us what good looks like, services that make diagnosis well, communicate them well, and then give people the care and support they need, and services that work for the whole community. And those improve people's quality of life and decrease behavioural disturbance. And we know that we can provide these for a modest amount of money within our existing communities. And the question has to be, why aren't they provided everywhere? But things are changing. So here we have data from GP Quaff registers. The numbers with dementia are increasing. There is increasing knowledge and understanding of dementia. There is increasing activity in primary and secondary care in terms of diagnosing people with dementia. The world is changing. There are reasons to be cheerful. And my reasons to be cheerful, part 3, is all about better prevention and treatment. We've heard about the the value of early diagnosis, but we're starting to understand how to manage people better in the community, how to manage behavioural disturbance better, how to support carers, how to provide good quality care in general hospitals as opposed to poor quality care in general hospitals. And each of these things has a win-win associated with it. So better quality care, better quality of life, and better use of resources also. All of those are possible in dementia, because what we do at the moment doesn't work well. And in terms of prevention even, these are data from the CFAT study. I know Harold Jagger's going to talk more about this later, but it's brilliant that it appears that the prevalence of dementia has inched down in the last 20 years. So here we have two population studies, CFAS 1 and CFAS 2, and the prevalence of dementia that we find in the population has gone down, and that's probably because of things at a population level that we have done in terms of improving our cardiovascular health and therefore helping our cerebrovascular health and therefore preventing the vascular component of dementia, and that's brilliant news. There's stuff that we can do that can influence the likelihood of dementia. So there are reasons to be cheerful. And I'll finish with this picture. Can anyone see that? So if I were a kind of biological psychiatrist, like many people who are involved in dementia research are, then that would be a picture of some bit of the brain. Okay? Any idea what that is? This is a picture of dementia. Okay? This is a picture of the Great Wall of China from space. Yes? You can see the Great Wall of China from space. You can see dementia from space. It's that sort of size of a problem. What's bizarre is that we haven't acted before to deal with the problem of dementia. What's fantastic about this moment is that we're starting to bring together the understandings and the tools that we need to be able to act with dementia, to be able to deal with this world-sized problem. So, and MODEM is a project that will help us to do that. So, thank you.